Learning objectives for this talk are listed here. I will have to say I usually believe that common problems in a newborn nursery also include issues of sepsis management, as well as dermatological issues and psychotropic medications during pregnancy and breastfeeding. However, I've been told that these topics will be discussed in other parts within this series, and so I'm going to limit myself to these topics listed below. Let's start with jaundice, hyperbilirubinemia. I'm actually old enough to remember a time when we clinically figured out jaundice based on how low the level of jaundice was on a baby. Previously, if it reached the neck, it was about a 5. If it was about the waist, maybe about a 10, and down to the feet, maybe about 15 or so. We've come a long way since then, and now we're doing universal screening, so we don't have to rely on such sort of crude clinical judgment. As such, what we are ultimately looking for in preventing is kernicterus, or bilirubin staining of the brain. If they survive, actually, the diagnosis is bilirubin encephalitis. Kernicterus is actually a diagnosis made at autopsy. The incidence of kernicterus is actually still pretty low, maybe about 1 out of every 100,000, but we'll get to this topic again as it's made more interesting since the advent of universal screening. There's still lots of kids who are commonly using phototherapy before discharge, maybe about 10% or so. We still have a tough time figuring out what is a safe level for jaundice. We know that the threshold for what we decide is a dangerous level rises as the age of the baby increases. And we still see kids who have fairly high levels of jaundice. However, what we've found is that it's not necessarily how high the jaundice is, but if you have a high level in conjunction with issues such as hemolytic diseases, Rh incompatibility, ABO incompatibility, that combination tends to show up with neurologic issues or soft neurologic issues later in life. So having a high level by itself doesn't necessarily mean that you are going to incur bilirubin encephalopathy. Basically, what we have found is, again, if you had hyperbilirubinemia that was high, along with Coombs positive or evidence of hemolytic disease, that is what's going to show up as more cognitive issues or behavioral issues later in life. We haven't really found an increase in kernicterus since instituting universal screening, which we'll talk about a little bit later. But at the same time, we haven't seen much of a decrease in kernicterus either, which poses an interesting question. And then there are some issues such as autism or other psychological issues that may show up for babies who have higher levels of jaundice. In this particular study, it was sort of nebulous as to how high was the significant amount of jaundice seen. When I talk to my residents about figuring out the physiology, the pathology, and the management of jaundice, I always say, go to this 3-part diagram. Bilirubin comes off of the breakdown of red blood cells. Some of it will combine with albumin, which would be great, but the majority of it will circulate through the body and make its way to the liver, where you will see the conjugation take place. The liver will distribute the bile into the GI lumen, at which point hopefully it will meet up with some kind of enteral fat. By making that mix happen, it will hopefully go out to the lumen, taking the jaundice out with it. But if there's no fat to combine with it, through active transport through the lumen as well as through bacterial enzymes, the bilirubin will be turned into a deconjugated form, recirculated through the body, and make its way eventually back to the liver. Hence, we call that the enterohepatic circulation. So without much fat, the bile will just sort of sit around and has the potential to become higher levels of jaundice in the body subsequent. You can imagine then why a normal newborn is going to get jaundice. They're going to have a higher turnover of a higher percentage of red blood cells. Their liver is going to be much less mature enough to be able to handle that bilirubin load. And especially if they're breastfeeding, there's not as much enteral fat to be able to move the bilirubin out of the lumen, and hence increase enterohepatic circulation. That is exactly what we call physiologic jaundice in the newborn. One of the corollaries to that is breast milk jaundice, which we typically see at about 2 weeks of age, which we believe to be some kind of enzyme within the breast milk which increases the enterohepatic circulation. Now, if you can go back to the same diagram and see that there is a way to establish pathologic means of jaundice, red blood cell issues such as ABO-RH incompatibility, G6PD, congenital spherocytosis, thalassemias are an issue. If the liver has enzymatic defects, these are your Crigler-Najjar's rotors or your Gilbert syndromes. And then issues that would obstruct your gut, leading to increased enterohepatic circulation issues such as atresias, Hirschsprungs, meconium ileus, meconium plug. I would say that the 3 times that I've ever had a kid who got jaundiced and didn't poop ended up having ileal obstructions. So what do we do now? We still use our clinical judgment in terms of evaluating a child who is jaundiced. If we see someone who's jaundiced, we're still going to test them and treat them if necessary. The old rule still applies, where we see that if baby is less than 24 hours old and seen with jaundice, that is pathologic until otherwise proven. And we're still going to encourage breastfeeding as much as possible. The more enteral feeding you can provide, the more fat will combine with the bile as a substrate and be able to move it out of the gut before it is recirculated into the intravascular space. We're still going to check RBO and RH incompatibilities to see if the kid is at risk for hemolytic issues. Don't forget to check for G6PD in your population. We do want to always inform parents before sending them home about watching for jaundice. And don't follow up too late. The AAP basically says that any child who is at risk for hyperbilirubinemia should be seen within 48 hours of life. So from my standpoint, that's pretty much every baby. Every baby is at risk for hyperbilirubinemia. We now are at a state where we do universal screening for all newborns for hyperbilirubinemia. You have 2 routes to do this, and we're going to come back and forth between these 2 ideas. One is the use of quantitative measurement, whether with transcutaneous, and we'll talk about a little bit about that, as well as serum measurements of bilirubin. And we'll plot that out on a curve to see if they are at higher risk for becoming hyperbilirubinemic, requiring phototherapy. The other method of doing it is using just a risk factor analysis to determine whether the child needs a quantitative measurement subsequent. Here's the list of risk factors that we typically follow, and majority of them are pretty self-explanatory. The most interesting one is the bottom one, East Asian race. We know that East Asians tend to peak faster and plateau longer. It is unclear whether perhaps East Asians can tolerate higher levels of jaundice early on better than other ethnicities, but as such we still end up treating them the same as everyone else. And therefore, if they have a higher risk of jaundice, we will end up treating them. Has screening worked? Basically, we have seen that the levels of high jaundice have dropped. The requirements for bilirubin exchange transfusions has dropped. However, we have not seen a drop in bilirubin encephalopathy or kernicterus, which implies that with the current technology that we have now, we're still not able to treat kids who are eventually going to become encephalopathic. When doing quantitative screening, you're going to use this risk factor analysis. This is a population norm. These are the famous Bhutani curves. And you can see that if you follow along this top curve, beyond this is the 95th percentile for the population, above which is considered abnormal for the age of the baby. It implies then that if you are in the high risk, that you are at a high risk for hyperbilirubinemia, which should require phototherapy. However, we do not use this curve for treatment. Instead, the AAP wants you to use these curves, which look strikingly similar to these risk factor curves. This one's the treatment curve that the AAP wants you to look at. It's stratified in a way such that the top line shows full-term infants with no risk factors. The middle line shows preterm infants or risk factors, and the risk factors here are different from the risk factor list that we saw earlier. This one, you can see, is much shorter. The only overlap is generally your ABO and RH incompatibility and your G6PD. The lower line implies kids who are preterm and have the risk factors. So let's look at a full-term infant with no risk factors. At 36 hours of life, the AAP would imply that you should treat these kids with phototherapy at about 13 and a half. But if we go back to the risk factor analysis, at 36 hours, those kids are considered high risk at 11. Therefore, the treatment curves are a little bit more generous than the risk factor analysis. So how do I sort of consolidate this idea? Basically, any child who has not met criteria for requiring treatment but is still in the high-risk zone, those are the ones whom you do want to follow more closely or make sure that they get their follow-up with their outpatient pediatrician the following day. The risk factor list that we saw in the beginning is also important, but realistically, the one that you really need to pay attention to is gestational age. If you find a child who is premature and also has a high level or high risk of jaundice based on quantitative analysis, those are the kids who will most likely be requiring phototherapy prior to their hospital discharge and the most at risk for bilirubin encephalopathy. Other issues. How do we know what is low risk? I mean, just because somebody is put in the low risk zone, does that necessarily mean that they are truly at low risk? Turns out that one study finds even of kids who end up getting phototherapy or readmitted for phototherapy, 4% of them were considered low risk. So be on the lookout and make sure you discuss bilirubin precautions with your parents prior to discharge. The treatment is still phototherapy, or the first-line treatment, I should say, is still phototherapy. And phototherapy is this blue light, and anything in the visible spectrum will work for phototherapy. But we use blue because it is actually the coolest in temperature and is the least likely to dehydrate the babies. Bottom line for this as well, the higher the intensity, the higher the irradiation that you can provide to the infant, the better the drop in the serum bilirubin level. When do you stop the phototherapy? We are all familiar with the idea of the rebound, where you stop the phototherapy and then at some point their bilirubin levels will jump back up again. If you take all the kids together, their median level of increase will be about 1.3. But the two populations of kids whom you should really get a rebound to make sure that it doesn't jump up much higher are, one, the babies who had their phototherapy started during the birth hospitalization, and two, those kids who had well-defined hemolytic disease, your ABO and RH incompatibilities. Again, those kids definitely should have a rebound before being sent home. Let's move on to late preterm infants. We define this group as about 34 to 36 and 6/7 weeks gestational age. Of all babies born in the United States, 12.3 are premature. But if you look at this small percentage unto itself, 74% of them are what we have defined as this late preterm cohort. So a very significant cohort indeed. Many years ago, I did the first study that looked at the outcomes of late preterm infants, and basically compared a group of late preterm infants with full-term infants. And down the line, we basically saw late preterm infants just did not do as well, whether it be temperature instability, hypoglycemia, requiring IV glucose, respiratory distress, or jaundice. The studies have corroborated this idea. Again, hypoglycemia and hypothermia are much more common in late preterm infants. Respiratory issues, GI issues, jaundice, neurological issues, kidney, liver, and immune issues. Other studies have basically also confirmed that late preterm infants are more likely to go to the NICU, more likely to require mechanical ventilation or respiratory distress issues. The question has always remained, does it matter what the maternal diagnosis is in terms of the outcomes for late preterm infants? The reason why I actually started the study was, at the time, celebrities were having their babies born at 35, 36 weeks by cesarean section, thinking that it would prevent the changes to their bodies in the late third trimester. No discredit to them. Nobody had told them prior to that anything would happen to their infant. We always thought that they would be just as robust as full-term infants. So the question had always remained, if the baby had been delivered electively, does that make a difference compared to the late preterm infant who had been delivered emergently? The studies basically show that it's a yes and no answer. Yes, if the mother had an emergent delivery for whatever reason, hypertension, diabetes, hemorrhage, those kids did tend to do worse than their full-term counterparts. But even an electively delivered late preterm infant did have an increased rate of morbidity compared to their full-term counterparts. And again, this study basically confirms that idea that an electively delivered baby also had a higher risk of going to the NICU than their full-term counterparts. It's very easy basically for me to say, based on that idea, that late preterm infants are going to cost more, up to 3 times more than your full-term counterpart. Looking at this data of length of stay and total cost, you can basically see that the majority of late preterm infants actually do just as well as their full-term counterparts. But as you get more premature, you'll notice that there are way more outliers, and hence these are kids who are going to be more at risk of getting poked and prodded and have higher morbidities. That is actually the bottom line of what I tell parents, is that yes, the majority of your kids at 35 to 37 weeks are going to do just fine. But be aware that as they are more premature, even though they are seemingly close to term, those kids who are more premature are more likely to be outliers, more likely to be poked and prodded. Is it just a gestational age issue, or is it maybe just the size or the weight? It's actually both. A small for gestational age infant overall has an increased mortality risk compared to their AGA counterpart. But if you incorporate an SGA baby who's also a late preterm infant, the risk goes significantly higher. So it's compounded between gestational age and their size. I want you to just basically think of one number when it comes to outcomes for late preterm infants. Basically, it's a relative risk of 1.5 or so. Late preterm infants basically will have an increase of 1.5 times relative risk compared to their full-term counterparts for whatever morbidity or mortality later in life, whether it be cerebral palsy, education, requiring special education, behavioral issues, developmental delay, disability, not reaching an overall level of achievement later in life, mental index, physical index, early intervention. The Scandinavians are very good at being able to follow people for their entire lives, and they've basically shown that late preterm infants were more likely to be manual laborers in the lower income range. But again, significantly more, but at a rate of about perhaps 1.2 to 1.5 times more than a full-term counterpart. Mortality as well, also higher. Mortality studies for late preterm infants have generally not factored out birth defects, which I think are pretty significant, but as such, they generally say that there is an increased mortality for late preterm infants compared to full terms. And the same idea, 1.1 to 1.5 times more. So how do we take care of these kids once they've been delivered? Every time I have a late preterm infant, I always go through a 5-point checklist. 1, respiratory distress. And we watch these kids on a CVR monitor for about 24 hours before we say, yeah, okay, they're fine and they can go back to mother's room. 2, hypoglycemia. By virtue of being premature, they're going to get tested under a hypoglycemia protocol as anyways. Temperature instability, they are just as liable to have low temperatures like any other premature infant, so I watch them very carefully. They should all have their car seat testing just like any other premature infant prior to their discharge. But the biggest issue is feeding. Of all the readmissions back to well newborn nurseries, 41% are for feeding issues. These kids are just not as neurologically well tuned up to be able to suck and swallow as their full-term counterparts. So we have a very low threshold to add supplementation. We generally use a 22-calorie formula, and for nothing else other than these kids will require that extra calorie to provide catch-up height to their full-term counterparts later in life. On standard infant formulas, they tend not to be able to make up that height. So for as long as the babies are going to be on some kind of formula, we do recommend 22-calorie formula supplementation. Again, the bottom line of what I tell moms and dads is the majority of these kids are going to do just fine, but as you get closer towards more prematurity, they are more likely to be poked and prodded. Let's move on to circumcision. So for decades, the American Academy of Pediatrics has maintained a very neutral stance on the health benefits of circumcision and has basically said that this decision should be made primarily by the parents for religion, culture, social, and family reasons. 2012, there was a policy shift based on some sort of game-changing studies where they're now saying that there are health benefits, enough that the American Academy of Pediatrics recommends that all male babies be circumcised. The decision still rests with the parents based on religion, culture, social, and family reasons, but based on a medical reasoning, they, again, do encourage that it be done. Generally, we think that there's about a 60 to 65% circumcision rate in the United States, which varies regionally and locally. That's compared to the rest of the world, which basically is non-existent except for religious reasons. The other aspect of the American Academy of Pediatrics statement is that all babies who have a circumcision done in a hospital setting should have pain management. The bottom line to this is there's really only one method that works effectively, and that is the ring block with a 1% lidocaine. That's a 4-point injection around the penis, and basically unto itself, by itself, works better than anything else with nothing else in adjunct to it. The medical issue with circumcision is actually more of a statistical debate, and you always have to look at your numbers carefully, but when you are looking at an odds ratio, always also think about your prevalence in the population. And this is going to come up pretty frequently in the argument to do it or not to do a circumcision. And actually, for those who play on different sides of the argument, they will play with these numbers to their advantage. Let's take one of the morbidities that we commonly see is UTI. I will tell you that there is a relative risk of 10 to 1 for incurring a UTI, 10 being uncircumcised over 1 being circumcised. And if you looked at that alone, you might think, wow, that is definitely worthy of doing circumcision on all newborns. But again, you have to look at the prevalence in the population. If I told you that 1 out of every 10,000 circumcised boys will develop a UTI, if you do the math of 10 to 1, that basically means about 1 out of every 1,000 uncircumcised boys will incur a UTI. Are you willing to circumcise 999 to prevent that 1? The majority of the studies on UTI and circumcision basically bear that same argument, where it's about a 10 to 1 relative risk and still generally pretty rare. And so it's almost a philosophical question for most people to decide, is it worth it to circumcise that many infants to prevent urinary tract infections? Penile cancer is even rarer. Out of circumcised males, we're talking about 1 out of every 100,000 who will incur penile cancer. And at a 10 to 1 relative risk, that means 1 out of every 10,000 uncircumcised men might incur penile cancer. The numbers basically don't bear out that it is cost-effective to circumcise for prevention of penile cancer. But the game changer, as I had mentioned before, is basically sexually transmitted diseases, particularly HIV. The preputial space is a potential warm, wet, and lymphatically rich medium for invasive bacteria and viruses. Ironically, there is literature that basically can confirm that being uncircumcised may protect against syphilis. Your various different sexually transmitted diseases, HPV, HSV, have been shown to be increased among uncircumcised men, but HIV, again, is the big news of the day. Whereas the other morbidities I had talked about were about a 10 to 1 relative risk, actually HIV is closer to 2 to 1, 2 being uncircumcised, 1 being circumcised. So you might think to yourself, well, it's not as big of a relative risk, not as big a deal. But again, look at the population. In the United States, HIV rates is about maybe 0.6% out of the entire population. But in areas such as sub-Saharan Africa, where you have maybe a 10 to 30% prevalence of HIV, a 2 to 1 relative risk can be the difference between saving and destroying the whole generation. In 2005, 3 different studies, all doing the same thing, basically took a cohort of men and divided them in half. One half received their circumcisions at the beginning of the study, the other half slated at the end, and then they followed these people over months to find out what the HIV acquisition rate would be. And very quickly it was seen that among the circumcised men, they had half the risk of acquiring HIV compared to the uncircumcised group. All 3 of these studies were stopped early in order to give the control group their circumcision and potentially save them. So the bottom line, based on these studies, which ended up being the game changer for the American Academy of Pediatrics to sort of change their stance and say that there is more encouraging news to do this and showing that there is more health benefit, the bottom line is they're saying circumcision among adult men in third world areas can cut HIV rates by half. However, the inference can be sort of shifted. Can you make the same conclusion for newborns in the developing world? And that's sort of the quandary that we're all sort of grappling with right now. Circumcision unto itself is not without its risks and complications. Just like any surgery, we discuss with the parents about bleeding, infection, damage or cosmetic injury, and even phimosis after the fact. The foreskin can grow at a rate larger than the shaft of the penis itself, and therefore can cover the shaft and create a level of phimosis. This recent study basically showed that overall about half of 1% have complications as a result of the surgery. The rarer stuff can be the significantly debilitating ones, such as urethral stricture, but more commonly the complications are seen as cosmetic, needing for revision. And that, again, is a result of the foreskin tending to grow more than the shaft of the penis itself. In 2009, I basically asked parents what they thought about circumcision, And then after that, we showed them the AAP statement at the time, which was a very neutral stance, and asked them, did that change their mind about how they thought about circumcision? And then after that, we showed them the HIV studies showing that there was a benefit to adult men in third world countries, and asked them, did it change their mind at that point? At each stage, didn't make a difference. Basically, we found that parents came into their child's birth with a belief about circumcision that would not change regardless of what anyone told them. So it means that circumcision in America is a very cultural phenomenon. Basically, it comes down to, especially for fathers, that they want their boys to look like other boys because, let's face it, the majority of men in this generation grew up in a time when the circumcision rate was probably about 90 to 95%. And so on top of that, they also want their child to look like them. The history behind how we got to a 90 to 95% circumcision rate post-World War II up until about the 1970s is fascinating. We don't have time to go into it in this hour, but I totally invite you to look up the history. It is very interesting. The myth that the uncircumcised male is harder to take care of and is more likely to be infected and have problems, believe it or not, actually stems from Benjamin Spock himself. In his first edition of his Care of the Baby book, he tells parents that to care for a circumcision, you need to retract the foreskin every single day. Now, the problem with that is forceful retraction of a pre-pubertal penis will basically tear the elastic ring of the foreskin, which is not meant to be elastic until, again, about puberty, so about, or pre-puberty, I should say, 5, 6, or 7 years of age. Retracting it at that point will basically tear it and basically increase your risk for infections, for strictures, for scarring, and therefore, if you leave it alone, the chance of all of these problems actually goes away. So that's what I tell parents of uncircumcised males, just leave it alone. This comes up commonly after circumcision. Does the baby have to urinate? And this study basically said of all circumcised infants whom they watched, all of them urinated within 24 hours of life. So don't hold up their discharge just because they haven't urinated yet after their circumcision. Contraindications basically are for ambiguous genitalia, and that does not include unilateral undescended testicles because that is not an ambiguous genitalia. It is when you have bilateral undescended testicles is when you worry about ambiguous genitalia. Hold off on your circumcision. It may not be a male. Cardiac anomalies are not a contraindication, and you don't need to have antibiotic prophylaxis for it. Okay? So what you're watching out for, at least traditionally we've been watching out for hypospadias and things that look like hypospadias, the chordee or the pointed forward penis, the penis with the incomplete foreskin, or one that is torsed. Even if you find something like that after you have slit open the skin, it turns out the surgeons can do just fine with it, and you should just go ahead and complete the circumcision. There is no problem for the future repair. Moving on to hip dysplasia. We call it developmental dysplasia of the hip because the hips are still developing after the baby is born. So even if they are seen with hip dysplasia at birth, a lot of times they are still developing and may do just fine weeks down the line. At birth, the hip is still really cartilaginous, and that comes into play in terms of radiological issues. When we talk about dysplasia, it must be fully dislocatable for us to say it is actually dysplasia of the hip. Okay? We think the incidence is about 1 in 1,000 or so for full dislocatable hips. When you are doing your exams, you do need to do that 2-part Barlow and Ortolani. Barlow is the pushing posteriorly into the bed of the femoral head. Ortolani is moving that femoral head up and around with a sweeping motion. Barlow is more of a dislocative maneuver, and Ortolani is a relocative effort. Okay? Imaging radiographs are useless in the first 4 to 6 months. We generally are going to use ultrasounds, but still you can't see anything for the first 2 to 4 weeks because there's not enough ossification going on there to see anything. There are lots of signs, subtle signs that one might be able to use, whether it be inguinal folds or leg length. None of these are pathognomonic for hip dysplasia, so don't rely on them. If there's one slide you should probably look carefully at for hip dysplasia, this is it, okay? The incidence of hip dysplasia is about 4 in 1,000 for boys and about 19 in 1,000 for girls. Why girls have more? It's believed that the girls have the receptors in their bones for the relaxins or the hormones that mothers have in the late 3rd trimester of their pregnancy that relaxes all the ligaments. And thus, if the pelvis is relaxed, maybe it does not move or model that femoral head nearly as well. And hence, without modeling, there's no joint formation. So having said that, seeing that girls have a much higher incidence, we find that these 2 risk factors, family history and breech, if you multiply these risk factors into the incidence for girls, you find that there's a high percentage of these kind of kids who are at risk for hip dysplasia. So, having said that, we basically say girls with family history or girls with breech are going to be at high risk for hip dysplasia, and these are the kids you want to ultrasound for later after their ossification can be visible by ultrasound. Certainly, you're still going to do your hip exams on all the kids, and if you find a dysplastic hip, you're certainly going to treat it as necessary. But in a normal exam, girls with family history, girls with breech, those are the ones you want to watch more carefully. A little food for thought here. Kids with breech who ended up having more time in labor were more likely to have hip dysplasia, and it says perhaps that these kids maybe have their hips popped out by having labor. Unclear at this point. And this study basically corroborates what we've just mentioned, which is that girls with family history or girls with breech are more likely to have issues with hip dysplasia. And this basically says, again, normal exam, you're just going to keep following them. But if they have a normal exam and are a girl with breech or a girl with family history, follow up with an ultrasound in a couple weeks. What if they were breech but then had a cephalic version? It turns out that even if they received a version, they are at slightly higher risk of hip dysplasia compared to their non-breech counterparts. But breech did end up doing some level of protection for them as well. And then what if you just left it alone and never found or never discovered that a child had hip dysplasia? It turns out actually that with children with true hip dysplasia, 80% of them are going to spontaneously resolve on their own, which led to sort of a movement among some pediatricians to say that we shouldn't even be doing hip exams for the risk of stretching out the vasculature of the femoral head and potentially creating an avascular necrosis. However, majority of studies afterwards have shown that what we do here in the U.S. does work, in that being doing hip exams on all newborns, trying to identify it by Barlow and Orlani, and hip ultrasounds for those who are at high risk. Again, the girls with breech or the girls with a family history. I put this here just to remind me to talk about swaddling. There was this study that came out and said that swaddling children will increase hip dysplasia. Unfortunately, this study defines swaddling as wrapping the child with straight legs, which basically keeps the kid in hip extension, and that does not promote hip modeling. Why would somebody do it like that? Apparently, it's very popular in Eastern Europe, sort of like an older generation idea that by wrapping them with straight legs, they're going to have graceful legs. They might have graceful legs, but if they have hip dysplasia, it sort of defeats the purpose in the first place. If you want to know what you're talking about when you're talking to the radiologists about their ultrasound, you're looking for two things. They want to see at least 50% coverage of the femoral head by the acetabulum, and they want to see what's called a beta angle that's close to 60 degrees. The beta angle is where the ilium comes into contact with the femoral head and the angle of the tangent of the acetabulum. And that, again, needs to be as close to 60 degrees as possible. If they have 50% coverage and 60 degrees on beta angle, then you have a normal exam. This is what you're going to do if you need to treat the baby. And the idea is you're going to put the baby in a flexed hip, abducted hip to, again, create a direct vector between hip, femoral head and acetabulum, and that will create modeling for the joint. Moving on to screening for heart disease in newborns. 2010, U.S. Health and Human Services recommended that we do pulse oximetry for all newborns. And subsequently, AAP has confirmed the mandate as well. We're not just looking for CCHD, we're also looking for non-cardiac issues, respiratory issues, infection and metabolic disease. A little note, if you do this at altitude, you need to be prepared for overall lower saturations, which don't necessarily preclude to true heart disease, but just that your algorithms for management may need to be altered. New Jersey was the first state to mandate this, and I put this date, August 31st, 2011, for a reason. They started on that day, and on the very first day that they implemented it, one of the 3 children found in the first 9 months of screening turned out to have true congenital heart disease. It was seen as a major victory, a policy victory, photo ops galore with the governor on that day at that hospital. So it provided some validation for those who wanted to do screening universally. We are typically targeting the terrible T's of congenital heart disease, the cyanotic heart diseases. But again, we are also looking for non-cardiac issues such as respiratory and metabolic diseases. Generally, you're going to put an O2 sat probe on a right hand and any foot to differentiate any aortic differences. You're looking at least 24 hours of age before you do this, because children underneath 24 hours of age are typically going to have O2 saturations less than 95%, closer to 92 to 93%. So more consistently used is post 24-hour saturation testing. And you're looking, generally, your target number is about 95% or better. So if you find a child who is not meeting that threshold of 95% or better, that's a kid who should get worked up, and good to call your cardiologist and your NICU specialist to come check this kid out before sending them home. I put this up as an example of an algorithm you can use in terms of screening, but it's the same idea. Right hand and a foot, and generally your threshold is about 95% or better. It costs about $6.28, and again, the probes tend to be single-use only, which is a significant factor in the cost here. Currently, there are no reusable probes for newborns, although hopefully the technology will catch up. However, the cost to treat an affected child with heart disease is about $20,000, but the gained amount per life per year is about $40,000. So conceivably, screening is worth it. But it does possibly make a difference in the cost-benefit analysis based on where you are born. This study just came out from my colleague at Brigham and Women's Hospital. And of all the children that they have screened in the first year of life, or in the first year or 1 year that they have been doing this study, only one child failed the screening, and the diagnosis was for persistent pulmonary hypertension, not for a significant congenital heart disease. At their institution, they have such good fetal ultrasounds that all of the children with CCHD were actually detected well before birth. So the implication is, if you have good ultrasound technology, is it worth it for you to do postnatal screening for everybody, and is it cost effective? Moving on to management of the HIV-exposed infant. There is an increasing proportion of women in the incidence of HIV in the United States. As such, more women and more women potentially having children, therefore more potential for infants who are going to be exposed to HIV prior to delivery. Without antiretroviral drugs during the pregnancy, the risk is about 1 in 4. So there is a sort of a three-prong approach to really decreasing HIV perinatally. One is making sure that moms get antiretroviral therapy during pregnancy. 2 is elective cesarean sections as appropriate. And 3, preventing breastfeeding for these potential mother-child partners. The majority of the time, HIV will be transmitted, if it's going to happen at all in the perinatal period, peripartum, not prepartum. And as such, that is why antiretroviral therapy during pregnancy is important, is to try to decrease the viral load as much as possible prior to the delivery. The recommendations basically are that we should screen all moms for HIV during the pregnancy. And that is a national recommendation. However, each state has its own mandates on how encouraging or how discouraging they are to doing universal screening, whether mothers do have the right to decline or whether they have the right to opt out of screening or not. Basically, again, we should be giving antiretroviral therapy for those women who are HIV positive during pregnancy, again, to reduce the viral load at the time of delivery. Now, it's questionable whether or not having a low viral load at the time of delivery should preclude somebody from having cesarean section, but we do recommend still that any HIV-positive mother should get a cesarean section to prevent contact during delivery. Also, it's unclear if rupture of membranes occurs before the cesarean section, whether that may affect the transmission of HIV to the infant or not. And again, we do want to prevent breastfeeding, as HIV is found in breast milk. Again, this is a recommendation for mother-child partners in developed countries, that these children should be formula fed. So what do we do for the newborn who is born to a mother who is HIV positive? Basically, that is a child who should receive at least 6 weeks of antiretroviral therapy, and as well as management and testing for the weeks and months subsequent. Basically, you will start the kid as soon as possible after birth with 4 milligrams per kilo per dose of zidovudine BID. They will get screening labs in the beginning just as baselines to detect any effects of the side effects of the zidovudine after you've started it. The first testing for HIV won't occur until about 2 to 3 weeks, and then months after that. And again, no breastfeeding for HIV-exposed infants in the United States or developed countries. I can't stress this enough, that kids in this cohort should be followed with your infectious disease specialist as much as possible. They are your best friends in determining the management of the dosage, whether azidovidine should be in adjunct with other retrovirals, and the labs that need to be followed for the months afterwards. 6 weeks of age, even in the asymptomatic babies, these children will need PCP prophylaxis.